Good afternoon, ladies and gentlemen. As a brief introduction for those of you who don't know who I am, and I've had the distinct pleasure of meeting many of you over the past 25 years. Gosh, that hurts to say out loud. But my name is Mervyn Levine. I am president and CEO of Spectrum Labs, which has been in business for 25 years. Our primary business to date has been serum allergy testing, being the first out of the gate in 1987 and continuing to innovate and grow as we have today into a company that is represented in 43 countries around the world. Once in a while, a revolution comes into medicine. And I don't use that word lightly because that was how I reacted when I first heard about a solution to biofilms. And frankly, I didn't understand the term biofilm, didn't know what a biofilm was, but I did understand the concept of chronic recurring bacterial infections. And that got me reading and learning more about biofilm. And all of a sudden, the next night I was watching TV and saw the Listerine ad, and for the first time actually heard the word biofilm used in any context outside of the literature. So Spectrum Labs basically made contact with Dr. Merle Olson's company, Innovatech, in Canada, and just agreed to represent this new product to the veterinary industry. So it's my pleasure to introduce you to Dr. Merle Olson. Dr. Olson is a DVM from the University of Saskatoon. He also has an MS from the University of Western Ontario. And he developed this technology at the University of Calgary, where he was professor of microbiology and infectious diseases in the Faculty of Medicine from 1984 to 2004. And he started this biofilm research back in 1984, before any of us even knew the concept. To date, he has 7,200 publications and holds more than 750 patents related to the biofilm industry. His first patent was, and published articles on biofilms, was in 1992, and in 2003 started Innovatech together with a group of investors and grew it into the company that it is today. And they've been using the technology for the development of new antibiotics, antimicrobials, and in the future even antifungals, which also are a source of biofilm. So without further ado, and as the saying goes, you've probably heard this many times, the following program is presented to you with limited commercial interruption by Spectrum Labs. I will, however, pick up at the end for the commercial. Dr. Olson.
As a fellow veterinarian, it's my really great pleasure to be here and talk about technology that I've always wanted to see transferred into the veterinary field. I've been very active and involved in the human and the industrial field regarding biofilms, but I think that this whole concept will really help veterinarians in their practice, as it did in mine as well. So I also just want to make one little correction. It wasn't 7,200 publications. It's greater than 200 publications.
Oh, wow. Mine sounded better.
I really wish it was that, but I can't imagine having 7,000 publications. Anyway, before I start, I just want to explain how I got into this, and I think how many of the veterinarians feel about why this is so important. I had a microbiology lab next door to a world-famous biofilm researcher named Dr. Bill Costerton. I noticed the work he was doing, and it changed my life. And I said, this really helps explain why we all had such many problems. We all know that we can send away a test to go to an MIC, and we look at the results, and we say, well, we'll use this antibiotic, and the treatment fails. And and we try another one. And sometimes we get to the state, well, what's the point in sending something in, because I'm just as good a guesser as what comes off that piece of paper. And but anyway, we then started working on where do biofilms exist in medicine. We looked at most in human, particular human infections like medical device infections, chronic pneumonias, prostatitis, and those are the kind of areas which we identified biofilms as being really important. And I think when you go through this talk, if you're not familiar with biofilms, and first of all, by the way, how many people here is biofilms kind of a new concept? So it's still a fair number. How many people were taught biofilms at veterinary school? Yeah, well, that's kind of, yeah. So that is actually, so I think it's in the microbiology, they're starting to introduce the concept, but really once you start understanding, you'll say, this helps explain all my frustrations. I'm hoping that'll help, that this does help you out. So the technology that I developed is actually this minimum, it's a test, basically the minimum biofilm eradication concentration, and it actually arose because we were spending time describing biofilms, on a urinary catheter, or biofilms in a prostate infection, or in otitis externa. But we said, well, it's nice to describe it, but unless you can do something about it, nobody wants to talk. There's no point in telling you, to your client, that your dog has got a biofilm there, so it's going to be really tough to treat. Well, you want to be able to say, well, we want to have a solution to a problem before you introduce a problem to somebody. And that's what one of the areas the medical field was lacking. A lot of description, very few solutions, and that's why we undertook to develop this technology. Okay. So what I'm just going to start off explaining just what are biofilms, and really what they really are. They're a community of attached or living, a community of bacteria attached to a living or basically an inert surface, like an abiotic surface. That's a urinary catheter, an orthopedic implant. They are a community of bacteria that attach to it. These bacteria are surrounded by an exopolysaccharide matrix. As soon as a bacteria becomes a biofilm, it attaches to a surface, and within minutes, it changes its physiology. It starts to produce what I call a sugar coating that helps protect that organism. So its metabolism actually changes within minutes of it attaching that surface. They're actually the predominant form in nature. And I always say, and also when you explain to your clients, if you went to the local stream that runs through your town or whatever, and say, and you ask where are the bacteria in that stream. Well, if you took a water sample, you may find a few bacteria, but normally you have to filter it. But if you just scrape the rocks, you find loads of them there. So basically, the bacteria on our clients, our dogs and our cats and cows, are actually, the animal is the rock. It's the surface where the bacteria, not where they are floating. And we know that, and that's a good example, is we know that generally if you have their animal has septicemia, they're fairly responsive to antibiotics. But we know if they also have an infection on a orthopedic device, we got big problems. And that's kind of the way these bacteria behave. It really is a survival strategy for these bacteria. It's how they can survive in nature. And this is more of a kind of a pictorial description. So normally, what we study in microbiology, and you grow, and we all took a microbiology, you grew bacteria in flasks, and you had them in tubes. These are planktonic bacteria. These are little bacteria that's in that solution, floating along. Those are planktonic. As soon as they attach to a surface, within minutes they start producing this exopolysaccharide. They also change their physiology. They're different. They're pumps of actually how nutrients are passed, so their metabolism totally changes. They then form what we call a microcolony. And I think everybody knows that these microbes, you have to look at some dogs with like one of the best described areas in biofilms is periodontal disease in humans and animals. That's a real heavy biofilm. That's exactly what happens. These things start really growing. I don't know, I just think, and they start, and you start developing this thick biofilm. They then, you can go back to the detached form, but very few come out and become the planktonic form again. They can go through the cycle, but generally the planktonic form are only there to seed the next area. So they actually then travel, they release the plankton, they go to another area, form a new biofilm. It's a way of transmitting the biofilm on the surface. It all makes sense. Why would a bacteria want to go out and hunt for its nutrients? It's better for it to stay there, produce a protective mechanism, and then let the nutrients come to them. And that's basically how that works. The second thing is, in this state, they're actually protected against even our own immune system. Phagocytes cannot recognize the bacteria within that biofilm. So, okay, now go to the next slide here. So, what microexist as biofilms? Well, pretty well almost all organisms, bacteria and even fungi and filamentous bacteria, filamentous fungi will also form biofilms. But some are much even better than others. Like the classic examples that we actually study and is well described in literature. And I should point out, actually, there is a textbook that's coming out next week called Biofilms in Veterinary Medicine. So, I mean, so now veterinary medicine is really starting to recognize how it's important it is in this area. But if you look at Pseudomonas, these are the ones we often have real problem, recurrent infections. They're typical things like Pseudomonas, E. coli, Proteus, Salmonella. Gram-positives, the classic one is Staphylococcus species. It can be in Listeria, Streptococcus listeria. Great example of in Canada, U.S., we have a lot of problems with, in the food industry of listeria outbreaks. The company goes in, they disinfect the thing, and they still can't get rid of listeria. Well, the problem is they didn't disinfect it, treating it as a biofilm. That's the reason why if they went in and used a disinfectant protocol as a biofilm, they would have more success. And that's the same, it's the same thing as that you're going to experience in treating certain of your infections in the animals that you take care of. We certainly see them other things like mycobacteriums produce nice biofilms. We also look at anaerobes like Fusarium, Clostridium fusarium, and of course the dental anaerobes are the classic biofilm in the teeth. We see biofilms that form yeast candida species normally have, and we also look at filamentous fungi also will form nice biofilms. Actually, we spend a lot of times as a company looking at biofilms on fungal biofilms on plant surfaces on very difficult to treat plant infections like Fusarium. Why? So I guess why is so important? Why are these so important? And why it's important for you to know that and to tell your clients about it. It actually helps explain why the client comes back and says, so you said you told me that this antibiotic is supposed to work and it doesn't seem to be working. What's going on here? Well, that is the most common form of these organisms. Almost all organisms exist as a biofilm. It said in a river, a stream, which is equivalent to on an animal, you would see about 99.999% of bacteria exist as a biofilm. That's how they exist in nature. So we should be approaching this, how to treat these things as the ones that exist as biofilms. The big issue is one of the factors, once they go onto the surface, they produce an exopolysaccharide. These exopolysaccharide are charged surfaces. They capture antibiotics. The second thing is the metabolism of bacteria, those antibiotics, is changed immediately. Almost immediately as they attach to that surface. So then, and of course, how do we kill bacteria? We kill them by interfering with their metabolic function. So if the bad part is, all our antibiotics, every single one of our antibiotics that were developed for human and veterinary medicine were developed using those test tubes, growing bacteria, adding antibiotics, different testing. They all were developed against planktonic bacteria. So on the other hand, one of these days, hopefully somebody will actually develop an antibiotic, biofilm antibiotic drug. And I think that's not far away, but in the meantime, we have to use the antibiotics that are out there in the market. So we have to find a way to use those ones against biofilms. And we certainly know we can't use the classic tests that we used to develop those antibiotics, which is the MIC testing. So we need to develop a way to identify how to kill those organisms as biofilms. Biofilms are responding for chronic infections, and certainly this is well known. If you go to the CDC's website on biofilms, they comes with 80% of chronic infections in humans are associated with biofilms. I suspect it's exactly the same way in your practice. They're extremely important in human and veterinary medicine, but also in agriculture and in industry. We often call we get called into problems in pulp and paper plants, and I just call those chronic infected plants because we have to develop, instead of using antibiotics, we use biocides. But it's the same idea. They know, actually, it's ironically, they're quite a bit ahead of all of us because they know that it's the only way they're going to approach that problem. So ask the question, why? Really comes, why are they so much more resistant to antibiotics? Well, of course, I said they inhibit the exopolysaccharide inhibits the penetration of that antibiotic through that exopoly sugar-coated surface, but they also, because the charges of our antibiotics are charged molecules, and so is the exopolysaccharide, so it has a real problem getting through. We call this a phenotype shift. So really, a phenotype is really what that bacteria is saying it exists. It's not the genotype, it's a phenotype, it's how that organism exists. So it is actually a totally different phenotype as a biofilm than that planktonic floating in solution. And so because of that, we have activation depression of certain gene expressions, and that results in impairment of actually the lack of the ability of the bacteria to be killed by the antibiotic. Remember that almost all our antibiotics come from, where do they come from? They come from fermentation of things that existed in nature. Well, remember, so these bacteria came from nature as well. That's one of their strategies. They've actually spent a lot of time, there's been thousands of years of developing a way how to be prevented to be killed by those bacteria. And we need new biofilm antibiotics, but now that with the ones that we have to find a way which ones are going to actually work them as a biofilm. Also, it's very important because they inhibit immune function. There's a lot of work showing if you expose, you can actually take bacteria. We did it. We put them as a biofilm as little implants into rabbits. Looked at actually. Collected the PMNs from those, the peritoneal, and they were not active against those biofilms. They didn't recognize that they were there. And that often explains why we have these chronic infections. And then one of the problem is because those bacteria keep growing and growing and growing, you really have overstimulation of the immune function. You have their products being released. So as biofilms get worse, the phagocytes can't get rid of them, and the immune system is recognizing it is actually being activated, and it actually causes some very significant immune problems. So why do we need a test for this? And again, I said I think it's kind of obvious, but I said our biggest frustration, after this time we started working. There was lots of descriptions, and you can go into the literature and find some beautiful biofilm pictures. And I didn't bother putting those in because You can find them everywhere. But the biggest issue is we need a way to treat those prominent form clinical signs. Right now, all we have currently for this test, only we can do is MIC, and you'll see some results. As often MIC test really doesn't help you pick up because it looks like any antibiotic should work. And then when we go to use it clinically, it doesn't work. This was a classic example in the cystic fibrosis children with Pseudomonas infection, cystic fibrosis. It's also in veterinary medicine a classic example of bovine mastitis. If colleagues who work on bovine mastitis, staph infections is an incurable disease. But if you look at the MIC of those, every antibiotic should work. The reason is they're testing against the wrong organism. So it's our explanation for treatment failures, the lack of reliability of MIC testing. And certainly if you pick the wrong antibiotic and keep using, you're actually inducing more resistance. And this is a classic testing. You can either use Kirby-Bauer or micro-dilution methods. All these are planktonic tests. They don't help you pick out what is a biofilm test. And certainly the whole test methodology, I invite you to go to the booth and we can explain that to you, how the tests work. But I'm sure your biggest importance is how is this going to help me out? Not how this test works. I'm sure the literature you had there will describe that. But really what you want is how is that going to help me in my clinical practice? And you can see that for this organism, that this is a Pseudomonas strain, but it looks as if most of these, as an MIC test, would actually work. But if you look at as a biofilm, you had very few things to pick. Either most of them are susceptible or resistant as a biofilm, but there's a very few ones you can pick out. So what it does is helps focus you down on what are the best antibiotics for that particular patient. Because I'm sure you've had many things that you've sent away because you're a frustrating case that come back, oh, well, anything should work on this. But you know that's not the case. So you're kind of, and veterinarians and human physicians are very good at helping, trying to select what's going to work, but it's still a frustrating problem because it's usually hit and miss. This really does help you focus on what antibiotics you're going to need to use. There's actually some really good papers out there. There's a really nice paper by a colleague of mine, Mario Jacques, actually. He trained under me at the University of Calgary, and he's in Montreal. But he went through all the different organisms in veterinary medicine where biofilms are described. And certainly there's lots of, but I wanted to describe, these are some of the main areas where it affects your practice. Certainly dermal and wound infections. These are really, and I'm using, this is as a general term, but generally staph are great at forming biofilms. There can be highly resistant, and picking the right antibiotics is critical. Obviously, periodontitis, and it's well known in both the veterinary and human field how important it is. Otitis externa and otitis media are clearly biofilms. That's why, that's why otitis externa is such a tough thing to treat. Also, it's why if you have children, you're taking them back to the doctor to have the tubes, new antibiotics, having the tubes changed for these children. That's why. It's because they're classic biofilm infections. Sinusitis. So I'm actually going through, I'm going through all your tough cases. And it kind of explains why. Sinusitis is another one. Chronic urinary tract, recurring urinary tract infections. Like chronic pneumonias. Lymphadenitis. Things like strangles in horses. Good example of a biofilm. Mastitis, staph mastitis is probably I call it a classic biofilm disease. And again, obviously osteomyelitis. In the human field, this has been very well recognized how important biofilms are. And again, recognize why if you have osteo, it's a nightmare. And On the other hand, so we've been using in cases where, because the problem is, if when you have osteomyelitis, if you have on your foot, they may amputate your foot, or you may actually, if you had some screws, they may have to take out the orthopedic device. You have to then be in a wheelchair for the next year before they can redo surgery. So trying to get these things treated early is really critical. And basically, as I said, any medical device, all medical devices are really prone to having biofilm infections. And we, as a lab, we have a contract lab. We spent half our time doing the technicians working with medical device companies to develop antimicrobial coatings for medical device, just to prevent it, because you want to prevent the problem if you can. This is actually shows you antibiotic susceptibility to different, these are children with cystic fibrosis, but you again, one is the, and this just shows you the difference in susceptibility between biofilms and planktonic, the percent susceptible. And you can see quite the difference. It's uniform with respect to almost every antibiotic. And I'd like just to point this case. This actually is kind of an interesting. This lady actually is was brought to us. She's actually was a veterinary student who had cystic fibrosis. She had been healthy all her life and responsive to all her treatments. She then she came to Delta exacerbation. She came in and the doctor treated what he normally been treating her. No response. They started guessing, no response. This is an early stage development. They came to us and we went through, we tested her, we told them what we used, and the doctor said, I would never have guessed that antibiotic or that antibiotic combination. We treated her, she responded, she just graduated from veterinary school this year. So this is a very typical story in this whole technology. That's why I kind of want to end that way, because it shows you it really can, this type of technology can really help you in your practice deal with your difficult cases. I think that in many cases, for the first line of defense, the first line you may actually be able to be good at picking up first antibiotics, but those cases that you just are obviously frustrated with, this is actually gives you a solution to try, because it is. I know how frustrating it is, these chronic infections that we keep trying and we keep trying something else, and things just don't seem to be getting better. And I'm really pleased with Spectrum Labs taking this over in the veterinary field, that we actually can use this to help make our patients better and help our practice. So I'm really happy to answer any questions this time.
Why don't we hold the questions till the end, if you don't mind, because then we'll pass the microphone around. It'll be easier for people to hear. I've just got a couple of slides that I want to go through. What does this mean, and why is it important, and how did Spectrum Labs get into this game? And we originally started because we're an allergy company. And as an allergy company, what is the most common thing we see are patients with chronically recurring staph pyoderma. So that was my initial level of interest, because too many times we're either testing a patient for allergies where the problem is a staph pyoderma, or the staph is a secondary to the allergy itself, and no matter how much we treat for the allergy, unless we can treat the staph, which in chronic cases, as you heard Dr. Olson say, is basically 80% of those cases are biofilms. So it's almost moot testing and treating for allergies unless we can get all the other chronic infections under control. So that was our initial foray into it. And then obviously as time went by, we started seeing a host of other bacterial pathogens that are equally important. And you saw from Dr. Olson the range of diseases. So we go far beyond allergy and dermatology. But certainly with regard to allergy, any otitis case is very likely, as is a recurrent pyoderma. But equally important are your periodontal diseases, your interdigital diseases, your catheters, etc., orthopedic cases, and the list goes on and on. So any time that you have a patient that has not responded to antibiotic therapy, or more classically, has responded but lands up back in your surgery 2 or 3 weeks after this course is finished, and they did great while they were on the antibiotics, but the problem came back. And the reason for that is that the biofilm, during the treatment of with antibiotics, the biofilm is resistant to those antibiotics. The planktonic bacteria get killed off. The biofilm is smart enough to go into a virtual dormant state. And as soon as you stop giving the antibiotic, the biofilm says, okay, the coast is clear, let's grow back again. And the infection and all the signs and symptoms are right back. And that's why you're seeing these chronically reoccurring infections. So basically, an interesting quote from Costas, and to those of us in the medical business must think very hard if we're to outmaneuver this very old and very successful bacterial life form, and perhaps learn to speak their language and even enlist them in our never-ending fight against disease. Now, believe it or not, biofilms were first recognized back in the late 1800s, early 1900s. So we knew that there was something. We knew bacteria formed these slimy films, but nobody really had a concept of how to deal with them. And one of the biggest problems is that up until now, growing a biofilm to subject it to antibiotics was a tedious process way beyond the realm of a clinical lab. So in a research environment where you had all the facilities and you had all of the money in the world from grants, etc., you could grow biofilms. But in a clinical environment, there was no way yet of doing it. So I'm not going to go through the entire basis of the screen, but essentially the testing for MIC and for MBEC, basically minimum biofilm eradication concentration, is very, very similar, but for one step. So we grow the culture and we subject it in a microtiter plate to a host of antibiotics, 15 or 16 antibiotics, depending on whether it was a gram-positive or a gram-negative strain. And we test it to see which of those will grow. Now, bear in mind, though, that, as Dr. Olson said, these are planktonic bacteria. So we get a set of results called an MIC, which tells us which antibiotics grow, rather which bacteria grow in the presence of which antibiotics and which don't. Then we take this innovative device that came out of the University of Calgary, which is basically a comb or a peg, a plate with 96 teeth on it, so to speak, pre-coded and pre-treated in such a way that when we expose that comb to the 96 wells, to those bacteria now grow as a biofilm on each one of those pegs. So we've grown a uniform biofilm on those pegs. Now we take that plate full of biofilm, and we subject it to the same plate, but now we're not subjecting the planktonic bacteria, we're subjecting the biofilm. And the results are going to be very, very different, as you've seen. I won't go through this. Basically, this is just the steps. First step is gram staining. Gram-positive and gram-negative get run through different panels of antibiotics, and then we grow a biofilm either on a gram-positive or a gram-negative plate. And in some cases, about 10% of the cases, you'll come up where there's complete resistance to every antibiotic on the screen. So there is no antibiotic available. In that case, we go back and we run a combination plate which is the same plate as used for Pseudomonas aeruginosa, which we know is highly resistant. And on that combination plate, we use combinations of antibiotics and increase the chances of finding sensitivity somewhere along the way. So here's what a typical report form is going to look like. Now, you'll see that on the left here is your MIC. And in the case of MIC, we had resistance, rather sensitivity, in all but one of the antibiotics. So we would have chosen we could have chosen 15 out of 16 of the antibiotics to treat with on MIC. Chances are that infection is going to come back. Why? Because that biofilm re-raises its head, comes back to life once we cease the antibiotic treatment, and look at the biofilm results. Very, very different. So in this case, we've got a lot more resistance and just a few of which are sensitive. Now, you may have been one of the lucky ones statistically and chosen the right antibiotic, the same one as came up positive on the, or sensitive on the MBEC and the MIC, and you may have got lucky. But statistically, you can see the odds are against us. So we report the results out as susceptible, resistant, and intermediate. Now, what is intermediate? Intermediate tells us that, yes, that biofilm did get killed off by the antibiotic, but it took the highest concentration that we test for in the lab, because we test for multiple concentrations to work out the SIR value. And if it's at the highest concentration of the antibiotic in the lab, then it's the one we want to choose as a line of last resort, because it's kind of on that borderline between sensitive and resistant. So we're going to look to our sensitive antibiotics first, and if there's no contraindications for one of those, then that's the way we're going to go. Now, these numbers that you see are the concentration of antibiotics that we've used in testing. And they're interesting because they'll show that even though you might find the same result, a sensitivity between, let's say on sulfoxetine, between the two, you'll find the number or the actual concentration of antibiotic is very, very different. But these numbers are not your guide as to what to use therapeutically. So you're going to still stick with the manufacturer's guidelines. And what you're going to do is, because you're dealing with a biofilm, you're going to use the highest recommended dosage by the manufacturer, unless for some reason it's contraindicated in that particular patient. Now, this particular patient was presented to us with recurrent staph pyoderma. It was one of our allergy patients. And this case had been going on for about 3.5 years and had been on every antibiotic and kept coming back. And as Dr. Olson pointed out, all that we did in the process was we increased the range of resistance to every antibiotic that we treated for, because we weren't treating for the right one right off the bat. So we increase our chances dramatically by going into this. Now, am I saying that every time you get confronted with a bacterial infection, you reach for this? Well, I would hope so. I would like that. But no, not necessarily. Because obviously, not all infections are chronic, and not all infections are planktonic, or a biofilm. Some of them are planktonic, and they remain in a planktonic state. But chronic recurring is a high number, and within chronic recurring, 80% of those are biofilm. So you stand a very excellent chance of landing up going down this road anyway. So there are some veterinarians that choose this as a first line of defense because they say, you know what, I'm going to go straight to the one that's going to kill the first time. I'm going to get the most client satisfaction. I'm going to get the most patient resolution, and all in all, everybody's going to be happy. So that becomes a personal choice. And it's interesting because when Dr. Olson started out in this room, and he asked how many have heard of biofilms or how many were taught about biofilms, very few hands went up. But if this room were filled with teenagers, every hand in the room would have gone up, because you can go to the Apple App Store and you can buy this program called biofilm. And it's about fighting bacteria on the computer. So our kids are learning it way ahead of us. I'm not going to get into any more of the commercial. You have the information in front of you. You're welcome to stop by our booth, which is, I had to double check, 837, and obviously we can give you more information and go into as much detail as you like. But I can certainly vouch for the fact that we've been doing this now on a low level, just to a handful of selected clients with tremendous success. And just to give you an idea of the potential of this, we have some veterinarians that send us 30, 40, 50 allergy samples a month, and we have some that send us 1 or 2 allergy samples a year. And the norm is somewhere in between those two. But I went to one veterinarian who sent us 2 samples last year for allergies. And I explained that we've got this test and asked him if he'd like to try it out and see how it goes. In a 2-week period, we had 7 samples from him. So clearly, it's an issue. We have a dermatology client who is testing on the high end on the allergy, and he's estimating that he's got several hundred potential cases a month. So clearly, this is an issue within veterinary medicine. It's an issue within dermatology, and it's an issue across the board. So for some of the ailments, it's new territory for us as Spectrum Labs. For some of them, it's a solution to the head scratching we've been dealing with for many years. So we're definitely looking forward to the road going forward, and to our relationship with Innovatech and taking it from there. Now, on that note, I'm going to open the floor to questions, and I'm going to ask you, so that everybody can hear your question, if you'll step forward. Lindy will bring a microphone as close as she can to you, and ask your question, and Dr. Olson will be more than happy to answer for you.
Two questions. One, I noticed on the antibiotic results, you had ciprofloxacin, which is a human antibiotic. What about using the veterinary antibiotics, marbofloxacin or enrofloxacin? Because, as I understand it, there's a question how well is ciprofloxacin. There's no work showing what is taken up.
Yeah, and one of the problems is we've developed this whole test. It's what antibiotics you put onto these, particularly even also in different jurisdictions, and as you can appreciate, there's only so much space on a test. So what we've done is usually picked up classes of antibiotics and used that. And I think that generally, from all our work we've done in the past, is that if you pick a fluoroquinolone, if a ciprofloxacin comes up, you would pick a fluoroquinolone as your therapeutic measure, because and that's actually, if you even look at some of the most diagnostics, we don't have room for all the tests, and that's really the only way. It's a practical issue, and that's. But one of the things we have with Spectrum, this is very new. I think as we progress on, we're not stuck in time. We'll design the studies as we get feedback from veterinarians. We'll divide the plates. We know we're going to have to do that. And
if I can just add to that, we had a case exactly what you're talking about, and they did go with one of the fluoroquinolones. So we do know that that the classes act as well as the individual bacteria. So we've definitely seen that works.
Okay. And then on biofilms, like in a chronic dermatitis, does shampooing help break down, or is there something that helps break down that biofilm physically?
Well, I mean, it will help, but the problem is that shampooing, a lot of things are on the macro scale, not on the micro scale. And really, a lot of times, these microcolonies of biofilms are actually could be either as an abscess form, or can they actually be within a root canal, And so really, the shampooing probably looks good maybe initially, but it probably is not going to help us out a lot in that respect. But there's no question getting rid of as much as necrotic debris. And my classic example, is, which I've done in both veterinary and human medicine, is on chronic wound areas. We know a venous ulcer, a diabetic ulcer. If you debride that thing enough times, which is basically almost several times a week, you actually can make any wound heal. But who can do that? You know what I mean? It's a practical issue. You know, so that's so basically so you need to kind of do some cleaning up as well as antibiotic therapy to actually try to get to actually be successful in some of these treatments. I mean, it's just a practicality issue for some of these things.
Another question? Anybody?
Merle, maybe you could just talk for a few moments about the differences that we've seen with MIC results versus biofilm susceptibility results as it relates to the trial at the Sick Kids Hospital in Toronto.
Yes, I mean, right now we're running a trial for this is one of the things that's hard to find case loads that actually help us do double-blinded clinical trials. It's not an easy thing in the human or in the veterinary field. But right now we're actually running a therapeutic trial for treatment of children with Pseudomonas cystic fibrosis infections, and we're looking at exacerbations. So we do know now that from actually going 2 years to this trial, we're still blinded to this thing, but we know that 71% of the time we would have picked a different antibiotic by using the biofilm test as against the planktonic test. We also know, clinically we know with CF treatment it's now the MIC test they've recognized it's not not much value, and so and I think this kind of reflects of what's going on in the whole medical field. We're desperately looking something to replace the MIC test for these chronic infections, and I think that I'm confident we'll certainly see that when that study ends. I should also point out some of the things that have just really happened recently. We people ask, is this test validated? Well, actually it is. Actually, what happened, we were actually approached by the FDA, EPA, and industry to help us develop a method to actually prove what things are going to work, how well they're going to work against biofilms, as well as how something that actually can be reproduced, so it can be used in industry and by regulators. And so recently, and most people haven't heard of this organization, it's called ASTM International, but basically it's an international body who develops standard test methods. So this whole method has now been given an ASTM number, it's approved. It's been validated by a number of different labs worldwide. And so the methodology is, that's one of the things you have to do when you have to, how do you get something accepted? It has to be a method that it can be a test method that can be accepted internationally, and actually has been, and the regulators were at the table. So really, we're kind of hopeful that actually may be a stimulus for industry to develop anti-biofilm drugs. And I think that's going to be, because I suspect within the next 5 years, probably the next 1 year, I suspect we'll have disinfectant biofilm claims, and there'll be antibiotic claims probably within 5 years. So, which will help all of us in our business.
We've just started our relationship and you're trying to put me out of business already? On a practical note, just to end off here, is how do you go about getting this tested? Essentially, all we require is a swab from the affected area, a swab in a carbon-based tube. Does not need to be sent refrigerated or on ice or any special form of treatment. We basically just need to have that double packed for Federal Express. We send you prepaid Federal Express mailers, and you would just drop the swab in there. We give you guidelines on how to take a swab from different parts, whether it's from a dry area or an infected area or a wet area. And or in some cases, for example, we've had orthopedic cases where there was nothing to swab. We actually had pieces of the bone fragments that were in. This was a orthopedic case that, in fact, the veterinarian who did that is sitting in this room right now, but that hadn't healed, and it was a compound fracture, and was not healing, and wasn't responding to antibiotic therapy, and as it turned out, it was a biofilm. And by sending in the fragments, we were able to grow the culture from the bone fragments and got that biofilm eradicated, and the patient healed. So it really is, it's limitless to where we can go with this and what parts of the body we can treat. I'd say it's any time you see any kind of chronically recurring infection, we hope that the industry will start thinking biofilm as a first line of defense. Thank you for attending, and thank you for staying through lunch.